from another hospital after resuscitated sudden cardiac death due to ventricular fibrillation. He experienced 6 episodes of in-hospital sudden cardiac death. One of them was 2 years ago, one year ago, and 4 of them in the current year. So what I need you to do is please do the anamnesis and the I will be the patient and I will try to tell you things about the patient, but please ask whatever it is interesting for you and might help you to do a proper diagnosis. Please, go ahead. Just be, nothing happens if you don't know, if you are wrong, if nothing happens here. So there's the chance to learn something from these cases, and maybe these cases are hard for you, but I want you to think, and I want you to think about things and to know exactly what do we think when we are treating these patients. So the first question. Come on.
Do we have to skip the part where we ask like the name, the age?
Yes, the name you can skip it, the age you have it. He is a married man, he has 2 kids, and he works as an engineer. Something else.
Does he suffer from any allergies or?
No, he has no allergies. Good point.
Does he smoke or
He was a former smoker. He quitted 6 years ago.
Mm-hmm.
Anything else?
Does he have, what about his family history?
His family history. He has no family history suggestive for cardiovascular diseases. And for congenital cardiovascular diseases, his mother was hypertensive, and his father suffered from a myocardial infarction when he was 50 years old.
Okay.
Okay.
I would maybe start with the chief complaint, first of all. Like, I mean, we know he's transferred because of the resuscitation, but like how he feels maybe right now and like what symptoms he has.
Okay, so you want to know about his complaints before admission, yes? That's right. Okay, he experienced some retrosternal pain, and he had no air. He experienced some palpitations before the event. And that's why he went to the hospital. That's very nice. That's a good question.
We can also ask about the characteristics of the pain before the event.
Great.
How long to describe it more?
Okay.
Things that make it worse or better.
And do you ask me what exactly?
For instance, could you describe the pain before your last event, or if you had any?
Okay, after the palpitations onset, there was a pain which was retrosternal with no irradiation. It lasted for 10 minutes. And what else?
Did you feel like fainting, or did you lose your consciousness at any point?
And then I lost my conscience and I don't know about anything else. Okay, great. That's very nice. Okay, so you found out that the patient fainted. He had a syncope because he lost his consciousness, and he had palpitations before the event. That's very nice. Anything else?
Medications. What medications are you currently taking?
So I have plenty of medication. Let me look through the slides because I don't know the medication by heart. So I have metoprolol twice daily, amiodarone, furosemide, and spironolactone daily, aspirin, telmisartan, and atorvastatin. I will tell you the amount when we get there. Anything else? Why don't I see you all? I don't know how to see you all. Okay. Go ahead. There are things you didn't ask. Okay.
What investigations have you done so far, or is this his first?
No. The patient had 2, 3, and 7 hospitalizations this year, and I don't have the documents, but he went through a coronarography twice in the last, I don't know, 5 years, which were normal, which resulted in normal coronary arteries. But until the investigations, you should have asked about his personal pathological way, yes? He experienced a myocardial infarction 5 years ago, and it was a late presentation myocardial infarction with normal coronary arteries. This is an important issue. You asked me about risk factors. Did you ask me about risk factors? No. He was a dyslipidemic.
I think we asked, right? Or
hypertensive. Okay, yes, Monica, sorry.
About his workplace, maybe?
He is an engineer and he doesn't work in a toxic environment.
Okay.
Great. So let's go, and some general considerations. You know the age, the sex, the job, the source of an anamnesis could be the patient and relative. You know these things, but I want to be clear once more. You can ask family members, friends. You can get your data from medical papers, from any document you can have. You should find out which were the main symptoms, one or more reasons for which the patient was determined to seek medical help, and this should be detailed description. The history of the present condition, a complete history in a chronological way of the problems that determine the patient to seek medical help, and this includes symptoms, risk factors, medications, and of course quality of life, because it is important to know the conditions in which the patient lives. Every important symptom must be described in detail, exactly like you tried to ask me. So If we talk about angina or anything else, localization, character, intensity, severity, onset, it was at rest or during exercise, the duration, the frequency, because the patient might have experienced angina, I don't know, a few times more before hospitalization. The condition in which it appears, at rest, during exercise, or after meals, or when he's getting into the cold. Precipitating factors, aggravating factors, remission of the symptoms, and of course associated symptoms. These are important things. And personal pathological history, childhood diseases, adulthood diseases, with hospitalizations, with treatment, medical treatment, surgical treatment. You did not ask me about any surgical intervention, and you have to ask me about risk factors and immunization. Family history, you did that. The diseases are important. The diagnosis is important when you're dealing with cardiomyopathies. For example, the age of death is important because it might imply young patients under 50 years age. Medication, name, dose, way of administration, the frequency of utilization. We have no time for this, but just to know that these are important things. And allergies, drugs, foods, factors of environment and insects. This is a nice thing with insects, and I will speak with you about that this week. Ask about alcohol, ask about smoking, life and work conditions, hobbies, and the patient's personality, because you know that is important for the patient. In this particular case, you should have asked me about syncope and prodromal symptoms, and you did, because cardiac syncope could be the cause. It is an arrhythmic cause here because you already know it's about ventricular fibrillation and sudden cardiac death, resuscitated sudden cardiac death. When it appeared during exertion or when supine, the patient was at rest, sudden onset palpitations immediately followed by syncope. It is the case of the patient. He had no family history of unexplained sudden cardiac death at young age. And what else? It is important to know if he has a structural heart disease or a coronary artery disease. And I told you that he does not have a coronary artery disease, but he experienced a myocardial infarction, late presentation, so he might have an ischemic cardiomyopathy. Palpitations, we said that. Angina, the description, if he had repeated episodes, he did not have repeated episodes. If the patient had heart failure, is it decompensated or not, but you could not know about this. What treatment did the patient have? Of course, it is important because diuretics could lead to electrolyte imbalance and could be the cause for the ventricular arrhythmias. In case of coronary artery disease, did he get a coronarography? And we talked about this. He did twice, and his coronary arteries were normal 5 years ago. He did not have a thyroid disease, and he did not use drugs such as cocaine or amphetamines. Okay, so what did we find out? We find out that the patient had myocardial infarction, inferior 1, in 2015, with consecutive half MREF ejection fraction. What is this heart failure with mid-range ejection fraction, with 40% ejection fraction. Does anyone know? Okay, you did not have the course for heart failure, yes?
No.
Okay.
We
Yeah, I think we're having it today after this LP.
Today and tomorrow you are going to talk about the treatment. Okay, I will tell you in just a couple of minutes. The patient had normal coronary arteries 2 years ago, 3 years ago, and in 2015. Grade 3 arterial hypertension with the systolic value of 250. He was known with ventricular extrasystolic arrhythmia. He was known with chronic kidney disease for 8 years, and he was a formal smoker. So what this heart failure with ejection fraction means? So we have 3 kinds of heart failure, and I will not go into details because the definition you will do the definition, and you will talk about this today with Professor Bogdan Popescu, and he's the proper one to talk about heart failure. Okay, you cannot have heart failure if you have no symptoms or signs of heart failure. So this is the most important thing to remember. You cannot have a diagnosis of heart failure if you do not have symptoms and signs. And then when we are talking about heart failure, we have 3 types of heart failure. We have the type with reduced ejection fraction. When we talk about left ventricular ejection fraction under 40%, and we don't need anything for the diagnosis. Signs and symptoms with the ejection fraction of less than 40%, this is HFrEF, heart failure with reduced ejection fraction. When we are talking about mid-range ejection fraction and the heart failure with preserved ejection fraction, we need additional criteria for the diagnosis. And this one is here, 49% mid-range ejection fraction, and over 50%, it's the preserved ejection fraction. To have a diagnosis of these 2, we have to have elevated levels of natriuretic peptides and structural disease, a dilated left atrium, and diastolic dysfunction. So we are talking about this one here, LV ejection fraction of 40% in our patient. Signs and symptoms, he had signs and symptoms once during his life, and we will see if we have elevated natriuretic peptides, but he was diagnosed with heart failure with mid-range ejection fraction. Okay, and what about the hypertension? Tell me, what is grade 3 hypertension? Grade 3, okay, I will not okay, grade 3. You know, optimal is under 120 systolic, up to 129. It's a normal systolic pressure. I will not go into details, but this is the classification you should know. Over 140 until almost 160, it's grade 1. Grade 1, grade 2, 160, 179, and over 180, it's grade 3 hypertension. So the patient was severe hypertensive. He had this event in 2020, 2019, and 18. We were especially interested in the potassium level because the patient had this chronic kidney disease, and this might have induced the ventricular arrhythmias, but you see the levels for the potassium were almost normal. This was low, but in the rest of the cases, he was he had a normal potassium. He was on antiarrhythmic treatment with amiodarone, carvedilol, mexiletine, and these medications did not stop the ventricular arrhythmias. Okay, this is the tracing we saw. What is this? This is an ECG tracing from the ambulance. Just say anything, it doesn't matter. What do you see here, for instance? You see a P wave and a QRS complex, yes?
Can it be Torsades-Dupont?
Can it be Torsades-Dupont? Oui. It can be Torsades if you look at this until here, but it's not very easy to say. For this particular moment, it is ventricular fibrillation and you should administer shock. You cannot say Torsades if you don't see a long QT. So if you see the long QT, you can say it is a Torsade, because Torsade is a form of ventricular fibrillation, but with long QT. That's it. So if you think this one here, so this is a P wave, QRS complex here, and the T wave. If you think this one is longer, I don't know, it's more than 500 seconds, it might be, but it isn't, because you see this one is 0.58, so between the RR, so it cannot be. It's suitable for ventricular fibrillation, and you know this event, which is very, very rapid and chaotic, starts with a ventricular event. So it ventricular extrasystole over the RT. So it might be a ventricular tachycardia. This is the tracing again. What does this mean, ventricular tachycardia? It means chaotic, irregular deflections of varying amplitude with no identifiable P waves, no identifiable QRS complexes or T wave with the rate over 150, but usually 300 per minute, and the amplitude decreases with duration. The coarse ventricular fibrillation transforms into fine ventricular fibrillation, which is very, very hard to resuscitate, and it does not respond very well to electrical shock. Okay, let's go further. The current medication, and you asked the current medication, is metoprolol, 5 milligrams bi-daily, amiodarone, which was stopped 1 day ago, furosemide, 40 milligrams daily, spironolactone, 25 milligrams daily. Do you know what spironolactone is? What is spironolactone?
It's a diuretic.
It's a diuretic. What kind of diuretic? It's a potassium
Preserves
sparing.
potassium. Yes.
Okay, great. Okay, you will have to prepare some presentations. I will not talk on Friday. You will. but I have to think about your presentations for Friday. So it's not homework, is a personal work at home. I don't know. It should take you no more than 1-2 hours to prepare your presentations, slideshow, and to share with us the medication in cardiology. And it will be a nice experience for you. No more than 5-6 slides, just to know the medication, the families, beta blockers, antiplatelet therapy, I don't know, diuretics, and so on, types and doses, and a couple of examples for which to prepare you for your exam. Yes. I will make a list and I will send it to you maybe tomorrow, Wednesday. I don't know. I will see. Okay. Aspirin 100 milligrams daily, telmisartan 60 milligrams by daily, and atorvastatin 40 milligrams daily. Clinical examination and biological status. Let's see. So the patient comes into the emergency department, and you know the things you know about this patient. You have seen the ECG tracing from the ambulance. What do you do next? You cannot ask me for the ECG because I will show you later, but you have to clinically examine the patient. So please tell me what you do first and what you need to know about this patient. Come on. So the vitals, which one are the vitals? What does vital means? Vitals.
Oxygen saturation.
Great. Oxygen saturation, 96% on air without oxygen. Great. Some other vital. If all the vitals are good, the patient cannot be dead in the future 10 minutes, I know. 10 minutes, 5 minutes. So you...
Body temperature?
Temperature. He was 36.7 was the temperature. Anything else? You have 2 vitals. Another one.
His pulse and the way he's breathing?
Okay, 47 beats per minute. The way he's breathing, what do you mean? If he can stand? If
his breathing, like his breathing rate.
Okay, great. Okay. Respiratory rate, yes. Another vital, 23 breath per minute. It's okay. So the patient has a heart rate of 47 per minute. He's febrile, SAT 96, and respiratory rate 23. You need 1 more, 2 more from vitals. Blood pressure, yes? 125 per 80 millimeters mercury. And diuresis, do you need the diuresis?
Yes.
Yes, you need it. Because the patient, if he does not urinate, you can think about shock, yes, cardiogenic shock. But he does, and he has a normal diuresis. What do you do next with his clinical examination? What do you examine?
His chest, like to see if he has barrel chest or I don't know. His skin.
Okay, He has no lesions, he has no incisions, he had no surgical interventions. So the inspection is kind of normal. Do you look for congestive signs?
For edemas?
Okay, great. He had mild pedal edema. What else? It is important in a patient with heart failure. You know, he had heart failure. He has heart failure.
Temperature of the legs, for instance.
Okay, his temperature.
Or the edema.
Are normal. They're not cold edemas. He has turgid jugulars, and he has a hepatojugular reflux. Anything else?
Facious, maybe. Is it normal?
Normal. Normal. Nothing important.
The color of his skin?
He's normal colored. Do you listen to his heart? You do?
Yes.
It is. It's not easy virtually, I know. So he has an LV gallop. It's sound 3 present, and an apical systolic murmur in the mitral area. He has no pulmonary congestion, so we hear no crackles when we auscultate the lungs. And a very important issue for a patient with heart failure, which has pedal edema, is the weight. He is 90 kilograms now at presentation. Okay, great. Do you need something to know from his biological markers? Is there anything you need to know in the emergency department?
Thyroid.
Okay, he has a normal TSH, so we did not do the other markers. His thyroid is normal. Great, great question. Why did you think of thyroid?
For instance, if we have hyperthyroidism, we have increased metabolic, so this affects the heart.
Okay,
it may lead to some kind of tachycardia.
Okay, great. This is one point. And another point is that you have seen the history of the patient. The patient was on amiodarone from 2015. And you know, amiodarone has some severe adverse reactions, and it causes thyroid diseases in most of the time, yes? So this is a very good question. Something else? In order
natriuretic peptide for
great, Nicolas. That's very nice. It's great. I will show it to you, but maybe not now. The natriuretic peptide, the NT-proBNP was very high, not very, very high, but it was 2000, so it was high, yes. Anything else?
Normal blood counts and electrolytic profile as well.
Okay, do you do troponin too? Troponin and markers for the myocardial necrosis? Do you need it?
Yes.
You might. But after resuscitation, it would be very hard to interpret it. Okay, NT-proBNP high 2000, troponin was negative, hemoglobin levels were normal, a little high. Maybe the patient was polycythemic, I don't know. The creatinine was 3.6, so he had a low filtration rate of 31 milliliters per minute, normal thyroid profile. The potassium was normal, 4.2, and the normal magnesium, LDL cholesterol was 121. Is it normal for a patient with the myocardial infarction? Or not? Okay, you don't know, no problem. We will talk about this tomorrow, about the cutoffs and the patients and categories of patients in which we should have a low LDL cholesterol. No, this patient should have 55 milligrams per deciliter after myocardial infarction, but we will talk about this tomorrow. Let's try to interpret his ECG. Go ahead, but the question is just try to have a systematic approach, a stepped approach in order not to miss anything.
He has sinus bradycardia.
Great, great. The rate is okay. You have some interpretation here, but I don't want the diagnosis. Please tell me, what is the rhythm? How is the P wave? How is the QRS complex? How is the ST segment? Just all these details. Okay, I agree with sinus bradycardia, but tell me the rate.
So first it's sinus rhythm because I see a P wave after each QRS complex.
Okay.
For the rate, let me see. So 1, 2, 3, 4, around like 40 something, 45.
Okay, something, yes, 45 exactly. Okay. It's here, so if you have some kind of a paper like this in your examination, you can look for this interpretation, but please do it yourself because it can be wrong here, yes. Okay. Something else? The axis. The QRS axis.
Let me see.
D1, AVF, positive. It's around 30 degrees here. Okay, this is the P wave, PR segment. It is normal or it is long?
Isn't it left axis deviation?
Is not really, no.
Because it's positive in lead 1 and negative in AVR.
Negative is normal to be in AVR, but no, you look in 1 and AVF.
AVF, yeah, it's positive,
okay.
So it's normal, yeah.
It's at minus 30 degrees, okay, but it's not really left axis like a deviation. Okay, the P is normal, the PR. Is it normal?
Is it a left atrial enlargement? Because if you look in V1, the negative part is a little bit longer.
Okay, it might be. Exactly, okay, good point. What next?
PR is also more than it should be.
It's more. It's more than 200.
200, yeah.
So it's a long PR. It might be a grade 1 atrioventricular block. Yes? Go ahead.
If we look at QRS, it's also enlarged from V3 to V6.
V3 to V6, but does it have more than 2 squares? 2, 3? No, not really. It's 2, and here in V6 is 2.5, and it does not meet the criteria for any bundle branch block. So it is modified, yes, this complex, but it is not very large. You see here in V3, it has 2 squares. How many milliseconds is this?
0, so it's 80.
Yes, 80, maybe 100, but it's not over 120. But it is modified, yes, and you see here a notch in the R wave, and it is a fragmented QRS complex, and this means maybe conduction delay in the ventricle, in the depolarization, yes. What else? Some little Q waves here and here and here maybe. How the Q wave should be in order to be a pathological Q wave? It should be more than 20% of the R wave and more than
0.04, yeah.
Yes, okay. It's kind of meeting one criteria. Okay, so that's it, the ECG. The patient had sinus bradycardia and first degree AV block. And he was in treatment with metoprolol 100 per day and amiodarone once daily. We don't have images for the echo, and I'm sorry for that. We will just point some things, but I will not insist. I don't know what you know about echocardiography, but just remember the diameter over 60 means that the ventricle is dilated. So when you hear that the diastolic diameter is over 60, that means the ventricle is dilated. He had a dilated left ventricle with the thickened interventricular septum and posterior wall. He had an ejection fraction of 40%. He had the left atrium enlargement, so he had another criteria for the heart failure. He had a moderate mitral regurgitation, which was functional, and the moderate tricuspid regurgitation, and he had some wall abnormalities, thin, echogenic, akinetic, inferior, and inferolateral LV walls in the medium and basal segments. So he had the proof of his inferior myocardial infarction. And I will not insist on this. What does functional mitral regurgitation means? A secondary mitral regurgitation. Do you have you have the primary mitral regurgitation, which means the leaflets are modified, and you have the secondary mitral regurgitation, which is functional. And this is an example, an illustration that I like to show you what happens when the ventricle is normal. So the ventricle is normal. Here is the posteromedial muscle with the cordage for the posterior leaflet and the anterior leaflet. This one here is the mitral annulus, yes? So we have the left ventricle, the left atrium, and this one here is the aorta. And we have these tethering forces in normal conditions. When the left ventricle is modified, is remodeled after a myocardial infarction, I don't know why it doesn't work. After a myocardial infarction, this one here is a scar, yes? And the papillary muscle is displaced and the portages are tethered. And this one here, which is the anterior leaflet, is restricted. So we will have eventually less cooptation of the mitral leaflets and mitral regurgitation. Is it clear for everyone? It's because of the remodeling and it's because of the increased mitral annulus since the ventricular the ventricle is remodeled. Did you understand this? Okay. So immediately after hospitalization, the patient presents these two electrocardiographic tracings, and let's see what's in here. The first one here above. Just try to make an interpretation. It doesn't matter if you do it correctly or not. This is sinus rhythm or not. D1, D2, D3, AVL, AVF, AVR is here because it is negative QRS.
No, it looks like ventricular tachycardia. Just from
where? Here, yes?
Yes.
Okay, but here, what is it here? So you have the P waves. P, 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 here, P. Okay, this one here are three complexes at a high rate. It is named how?
Triplet.
Okay, triplet. Okay, great. And here you might have a ventricular tachycardia, yes? It is sustained or it is not sustained?
Not sustained.
Not sustained, okay. The QRS morphology is how? You have a QRS morphology with an aspect of left bundle branch block or right bundle branch block. It is kind of left, yes? You don't have the M appearance for the right bundle branch block. It is regular or irregular. It is kind of regular here and regular here, but something is happening between these two. So it is an irregular event which started with a ventricular ectopy. So we might think it is a non-sustained tachycardia. It is a hard case for you, I know, but I just want to talk about this to be more clear. So a broad complex tachycardia originating in ventricles, several different types of ventricular tachycardia, but the most common is the monomorphic one, and we will see a monomorphic VT in a couple of minutes. You have to describe always the morphology. You don't have to put the diagnosis of ventricular tachycardia, no. Just to describe the tachycardia with the large QRS complexes, with the morphology, it is monomorphic or polymorphic. The duration, it is not sustained if is less than 30 seconds, and it is sustained if it's more than 30 seconds or is requiring intervention due to hemodynamic compromise. And a very important issue, if the patient was hemodynamically stable during this tachycardia, or the patient was hemodynamically unstable from hypertension, chest pain, cardiac failure, decreased conscience level. And if you have an unstable patient, the treatment is what for ventricular tachycardia? Immediate electrical shock and nothing else. So immediate electrical shock, sometimes without sedation, because we do not have time to sedate the patient, and it's not a good experience. What are the features for VTs? A rapid heart rate. I don't want to be very hard for you, but we must have these characteristics. We must go through this. Rapid heart rate over 150. Usually very broad complexes, the absence of a typical right or left morphology. We have extreme axis deviation. We can look over. In this case, we had right axis deviation, not extreme right. This is called northwest axis or no man's land, with QRS positive in AVR and negative in D1 and AVF. We have P and Q complexes at different rates dissociated. Capture beats, fusion beats, concordance through the precordial leads. Of course, Brugada sign and Josephson sign. I will not go into this because you had the course for ventricular arrhythmias, and I'm sure you talked about these features. And this is the most specific finding in favor of a VT. If is the left rabbit ear pattern, it is this one, like RS R prime, with the left compound, which is more taller than the R prime here. So it is the most specific finding in favor of a VT. And in hospital medication, we thought it is suitable to increase the dosage for furosemide in continuous IV administration, and we increased the spironolactone to 5 milligrams daily. Does anyone know why we did such things? Why? Because the patient had 40 milligrams and we just increased the dosages at 100 milligrams, the spironolactone to 50, and we kept the amiodarone, we kept the metoprolol at 50 by daily, so that means 100 milligrams, and the rest of the treatment was the same.
Reduce the preload, so because of the congestion.
Great, to reduce the preload. You saw that the patient had also the diastolic dysfunction with high filling pressures, and most important, the patient was congestive because he had bilateral edema. So we needed a higher dose of furosemide, and because you know the adverse reactions of furosemide that lowers the potassium, we thought it would be good to increase the spironolactone too. Okay. Besides monitoring the treatment, and we will talk about how we do so, what is the next step? What would you do for this patient now? Because you saw the arrhythmia during hospitalization and the patient just repeated the ventricular arrhythmias. Up, up, up. So next, what should we do?
Think of surgical treatment.
How? Okay, we have a patient with sudden cardiac death with ventricular arrhythmias, we must think about the causes, yes? What is the most frequent cause to produce the ventricular arrhythmias? Ischemia, yes, coronary artery disease. He is an ischemic patient with a lot of risk factors, cardiovascular risk factors. The first thing to exclude is coronary artery disease. I know the patient had a coronarography 2 years ago, but it is not enough for this particular hospitalization for this moment. So we must go ahead again and see what's happening with the epicardial coronary arteries. Structural heart disease, we can think of a scar, and the patient had a scar because in the echo we saw that he had a thin akinetic inferior wall. We can think about long QT syndrome, but this patient did not have a long QT on his EKG. The imbalance of electrolytes, and we excluded this. The medications side effects, a pro-arrhythmogenic effect of amiodarone, and we must be clear about this aspect. The patient is using or is not using drugs as cocaine or methamphetamine. How do we monitor the treatment with diuretics and the treatment for the patient with heart failure? Should we do anything? So we have a congested patient. We give him diuretics. How do we know the treatment is good or bad?
Body weight?
Body weight, great. Another thing. Body weight. Daily body weight. Another.
Natriuretic peptides, maybe?
Natriuretic peptides, maybe not now because it's his first day, maybe in 2-3 days, eventually. Okay. Do we need some biological testing? Creatinine, sodium, potassium levels? We do, because of the adverse reactions furosemide might have. Okay, we will talk about this. So we are going for a coronarography that is a guideline indication. I don't want you to know the guidelines indications. It is enough just to hear about this stuff. Coronary angiography should be considered to establish or exclude significant obstructive coronary artery disease in all patients with life-threatening ventricular arrhythmias or in survivors of sudden cardiac death who have a probability of having coronary artery disease. So the epicardial coronary artery disease were normal in this patient. What else? What do we do next? Are you really 28 here or not? You're not.
I'm not very sure what we should do next.
Okay. Okay. So a workup with reversible causes for the patient. This is an answer to, and I don't want to speak alone, with the 6H and the 6Ts. It is not important. These are the same for sudden cardiac death in case of resuscitation. I will not go into details, but the patient had no such pathologies. The response was very good of the patient. the response to the treatment. So in 4 days, he had increased his urinary output. He improved his organ function. His creatinine reduced. His potassium was normal, no peripheral edemas, and no pulmonary crackles. So he improved his congestion sign, was symptomatic only on minimal exertion, but he had the documented ventricular arrhythmias. Okay. What next? What next? This is kind of hard. Okay, I need to have a phone call into the hospital for 3 minutes. Can we stand? I don't know. Can we grab a coffee or something? 3 minutes?
Yeah, great
Yes.
idea. Let's grab a
Great.
coffee.
No worries.
Okay, thank you. Okay, I'm here. Sorry.
That's okay. Welcome back.
Okay. You're here too, or am I just talking alone?
I'm here.
Nicolas.
How's the rest? Hi.
Okay. So what next? We have ischemic cardiomyopathy, as we have seen. We have the ejection fraction of 40%, a patient with heart failure with a mild reduced ejection fraction, who presented resuscitated sudden cardiac death and non-sustained ventricular tachycardia. What do we do next? Do we have any option? What do you think? We don't have any option but to implant a cardiac defibrillator, and this is a device. You know what this device does? We have a class 1 recommendation for the implantation in patients with documented ventricular fibrillation or hemodynamically not tolerated ventricular tachycardia in the absence of reversible causes or within 48 hours after myocardial infarction, who are receiving chronic optimal treatment, medical therapy, and have a good survival rate over 1 year. This device is implanted transvenously, just a second, here through the superior vena cava into the right ventricle, apical right ventricle. And it does two things: sees the rhythm the heart is in and recognizes when sudden cardiac death is taken place. So when we have ventricular tachycardia or when we have ventricular fibrillation. And it has the second effect to deliver therapy. The first therapy, I don't want you to know all this stuff, but you should hear about this in the cardiology course, because you can experience this with one of your relatives, I don't know, and you have to hear about these therapies. To deliver therapy, one therapy is anti-tachycardic pacing, ATP, which is a very rapid pacing of the device, just to remit the ventricular tachycardia or the ventricular fibrillation. And the second therapy of the device is the electrical shock. You see here, this is subcutaneous in the left subclavicular area. It has a battery, a header, and the connectors with the leads. The leads are maybe just one lead in the right ventricle here, or maybe it has two leads in the atrium too. Okay, so the patient got a bicameral cardiac defibrillator with two leads, one in the right atrium to make the sensing and to keep the atrioventricular conduction, because you know on his ECG he had a grade 1 block and bradycardia. So we wanted to put him on the correct treatment with beta blockers, and we needed the lead in the atrium too, and one lead in the right ventricle. The pacemaker, the defibrillator was programmed, and I don't want you to know the programming. So this was the ECG. What do you see here? It is not very hard. You only have to say what you see. You don't have to make a diagnosis or something else.
The spikes?
The spikes, where do you see the spikes?
In V1.
Okay, where?
There.
Here?
No.
Here? Here, here, before the QRS complexes. Do you see another spike? This is a spike too. This is the atrial spike, yes? One atrial spike, one ventricular spike, ventricular spike, ventricular spike, ventricular spike. Okay, we have one atrial spike and one ventricular spike. The QRS have the morphology of right or left bundle branch block. Left. So it comes from the right. Yes, it comes from the right ventricle. It is a good positioned device. Let's go. We updated, we optimized the medical treatment. We now can go to metoprolol 200 milligrams by daily and amiodarone 200 once daily. That lowers the necessity of electrical shocks, lowers the device's intervention, reduces the risk of recurrency, reduces the risk of sudden cardiac death, but it had been shown that it does not reduce the risk of mortality in these patients. We now have furosemide 60 milligrams daily, spironolactone 50 milligrams daily. We will talk about this treatment after your course on Tuesday, maybe after the treatment for heart failure, because it will be more easier to understand. We have atorvastatin and magnesium to help us with the ventricular tachycardia. So the response to the treatment were episodes of non-sustained ventricular tachycardia. And this episode here with hemodynamical instability and with the electrical shock, I guess this one was before the implantation of the device. I'm sorry, I wasn't very attentive when I put this ECG here. Let's interpret this ECG because it's a nice ECG. This one was before the implantation of the device. Let's see what's in here. If you have this one in your exam, what would you say?
It looks nice.
It looks nice. Not really. If you see this one in the emergency department, it won't look very nice. Your evening will be ruined. Let's start with the beginning. Do you see P waves? Do you see any P wave?
No.
No, you don't see. Do you see ventricular QRS complexes? You see QRS complexes, yes? This is one here. So you have the AV dissociation, one criteria for ventricular tachycardia. What can it be, this one? It could be ventricular tachycardia or supraventricular tachycardia with aberrancy, yes? You just have to decide which one is it. So you have a tachycardia, first of all. What's the rate? The rate is somewhere 300, 150? 300, 150, 140. 150, let's say. Okay. The QRS is large or not?
Large.
It's very large. We have a large QRS tachycardia. It is monomorphic or polymorphic. Do you see the same morphology of the QRS complexes, or you see just one morphology?
Monomorphic.
Monomorphic, great. This one here has the aspect in V1, V2 of right bundle branch block or left bundle branch block.
Right one.
Great. And you see this aspect of R as R prime with this R which is larger than, taller than R prime. So it's the left rabbit ear aspect. It is typical for the VT. And for more accurate information, the QRS complex is positive in D2, D3, and AVF. So the axis goes, the vector goes from up to down. So from the base to the apex of ventricular from the base, the ventricular base to the apex. And we thought that this one came from the scar. Okay, the interrogation of this device, you don't have to understand anything from here. You just have to remark the notches and the multiple episodes these patients have of ventricular tachycardia and ventricular fibrillation. So the interrogation of the device showed that the electrical shocks had a real substrate, multiple episodes with 2 intracardiac morphology. What does this device? So, I told you so, it does 2 things, 2 therapies. The anti-tachycardic pacing, which was here, a pacing with high rate pacing, and this one could terminate the ventricular tachycardia, but it didn't, and the arrhythmia was reinitiated. After that, the electrical shock was taken into consideration, and this was done by the device. Another reprogramming of the device with the thresholds, but I don't want you to know about this, and another optimization of the treatment. Finally, another diagnosis workup. So, what do you think about this patient? First of all, we think about the etiology. It could be a hypertensive cardiomyopathy along with ischemic cardiomyopathy with intramyocardial remodeling and with LV hypertrophy, with scar, ischemia, and a lot of fibrosis. It could be the proarrhythmic effect of amiodarone who induces the tachycardia. And the mechanism would be re-entry with 2 circuits. Maybe the scar tissue is very heterogeneous because you have seen it had 2 morphologic intracardiac aspect. This is too much for you, and I will not go into details, but the final approach for this patient is to consider if appropriate shock is the reason the device gives shocks, or it is inappropriate. If it is inappropriate, so you have to reprogram the device. But if it's appropriate and you do all these things, antiarrhythmic agents, sedation, optimize the device, and nothing happens, then you should go for ventricular tachycardia ablation, which is the main treatment. We have chosen our treatment. First of all, we have to optimize the heart failure treatment, evidence-based medical treatment, because this is the first to do in a patient with ventricular tachycardia and ventricular arrhythmias to optimize the heart failure treatment. You did not talk about the treatment, so I cannot talk about the treatment with beta blockers, with diuretics, any time in heart failure, and with AC inhibitors and sartans, very important, with MRAs, spironolactone. This will be discussed tomorrow, and maybe we will have the chance to discuss some other case with the treatment of heart failure. We must think about precipitants, potassium, magnesium, and reversible causes, and very, very important comorbidities, but because patients with heart failure have many comorbidities, and we are talking about pulmonary disease and about iron deficiency. All of these must be corrected. And if we do not have any choice, we must sedate these patients, and sometimes we need to give them anesthesia, because it is very painful to be in just shock after shock after shock during hospitalization. Antiarrhythmic treatment, the almost last therapy with amiodarone and beta blocker, and maybe another kind of beta blocker except amiodarone. I will not go into details again. And the last thing to consider is catheter ablation. Urgent catheter ablation in experienced centers, and probably you will go into centers that are experienced with this technology. It's catheter electric therapy to reduce the zones, the area of triggering these ventricular arrhythmias is the treatment of choice for this patient. And the particularities of this case was that this patient survived sixth sudden cardiac death due to ventricular tachycardia before ICD implantation and electrical storm, because this was a electrical storm. The definition for electrical storm is several ventricular arrhythmias, multiple internal shocks, and increased number of events after ICD implantation. So the definition for electrical storm that can appear in different clinical settings, and it is associated with high mortality rate, is characterized by severe severe arrhythmic instability in form of recurrent ventricular arrhythmias leading to frequent ICD interventions over 3 in 24 hours. And the catheter ablation is the treatment of choice for this patient with electrical storm. And that's it for today, because I wanted to be just a 1 hour practical session, and we were late in our beginning. What do you want for tomorrow? I know it was a difficult case, this one. What do you want to talk about tomorrow? Is there anything you would particularly want to talk?
I think anything that you believe is relevant for us in this class.
No, you must hear about stuff, and a lot of stuff, and because you are not coming to the hospital, it's very hard to have I don't know, a general view over cardiology, and that's why we are trying to give you some clinical cases. Ones are hard, ones are not. Okay, I will think about some clinical.
I think what we did today, like with the clinical cases and all of that, was really good.
Okay,
like clinical case and also ECG together.
Okay, ECGs and
ECG
clinical.
practice. Yeah.
Okay, but pay attention. Maybe you get one more look over the anamnesis and the clinical examination, just to put me some more questions about the patient and to tell me what you are going to do if you examine the patient. I don't know. I want to auscultate the heart in the mitral area, in the tricuspid area, just to imagine how you would do if you were near the patient. When are you coming to the hospital? Next week?
On the 1st, I think.
On the first.
Well, each of us go on different weeks, like in groups of 11. So some of us are going next week, some of us are going the week after. So.
Okay. So with some of you, I will meet in the next weeks, maybe on the monitor, on the emergency department. But with all of you, I will meet tomorrow. Yes, and I will see. I will think about this for tomorrow.
I have
Okay.
a question.
Yes.
Can we get the presentation